his balance was poorer. Clinically, he had Parkinsonian features, but he only had a small fall in blood pressure in the clinic. So he didn't really have postural hypotension by definition, which is over 20. Now, what could the diagnosis be here? And it's different from the other ones. The diagnosis here is that he had Parkinson's disease, hence his motor deficits. He also had autonomic failure, which caused orthostatic hypotension, but not usually when upright. It was mainly after food. So the history was important, and also the fact that you can be testing them in the laboratory. Just to give you some examples of these sort of conditions, they could be acute, which are fairly rare. They could be chronic. We've given you two examples: pure autonomic failure, Parkinson's disease. There is a rare condition called, or relatively rare, called multiple system atrophy, where there's more than Parkinsonian features, and unfortunately the prognosis is quite poor. It's difficult to separate, but it's very important to diagnose. And increasingly, as we find in the elderly, there's a condition called Lewy body disease. So they might have some Parkinsonian features. They don't think so. There may be a touch of dementia, and they've got marked autonomic failure in some of them. So these are conditions which should be picked up and therefore treated. These are what we call primary, but there are a whole range of what we call secondary, where we know what the condition or the cause is. They may be genetic, and some of them are relatively rare, such as those patients with dopamine beta hydroxylase deficiency. Those are the ones where the noradrenaline was 0 on that slide. It could happen to any of us due to trauma, high spinal cord injury. It may be a very common metabolic condition. And Krish, thank you for your slide the other day that 20%, I think, from Dick's Mayo Clinic Laboratory with neurological and possibly autonomic conditions. And of course, we talked about drugs which can cause it. Now, I just showed this briefly. I'll just give you one or two examples of treatment, by the way, but the doctor, of course, should know what the cause is and what the mechanisms are. And of course, these days, increasingly, the patients, they've got recourse to the internet, so they can learn as much, sometimes even more than the doctor does. And I said there's no time for this, but there are a whole range of factors, non-pharmacological, and you're very fortunate that in Chennai that there's a whole range, and I'm pointing to Dr. Krishnamurthy and his departments which have been evolving things. There are a whole range of drugs which can be given to help with this. I'm just going to talk about one drug. Before that, drugs are expensive, of course, anyway. But sometimes there are fairly simple, cheap methods, one of which is 2 glasses of water, which raises the blood pressure. Surprisingly, no time to go into the details. And I think somebody asked when this was seen, this is part of our back garden, as it were. But in England, of course, it rains all the time, but it hadn't rained at the time, so it's actually quite dry over there, which is why I thought it would be useful to put that up. Now, we talked about those patients, very rare, with dopamine beta hydroxylase deficiency. This is where this enzyme here is missing. And it's important because if you look at the formation of noradrenaline, the chemical we talked about in adrenaline, it comes from various substances, but the precursor is dopamine, which is converted by this enzyme into noradrenaline. Now, you might say, what's the fuss about? Just give noradrenaline by mouth. But you can't, because it's chewed up in the gut, just like dopamine. So there is a drug which, years ago we managed to get from Japan, which is converted by this enzyme into noradrenaline. So it bypasses the deficit and is very useful. So it's now the only oral drug which is a replacement therapy for noradrenaline deficiency. And I'll just go through this quickly to show you what happens when Parkinson's disease. This is with levodopa. It's converted into dopamine, so you can give it by mouth because of this enzyme, dopa decarboxylase. The same with L-DOPS. You give it by mouth, and it's converted into noradrenaline. So this already has, and I think is going to make a tremendous amount of difference to the management of these patients. I quickly add that it's taken a long time to get this through. It's just been approved by the FDA in the United States, and it's up before the European Drug Authority. And so these things take time, but it'll make a lot of difference. And I give you one example here of an ongoing study, but even at this early stage, this is in Parkinson's disease with autonomic failure. You find that when you give placebo, that's the number of falls, and you can more than halve them when you give the drug. Keeping in mind that, of course, falls in Parkinson's are also due to the motor deficit, so it could be even more effective when you don't have Parkinson's. What are we trying to avoid? You've seen that slide, the trauma to people. And I show you this slide, which will come up again, in fact, although it's for a different condition. You can actually have a break. This is a patient of mine who had a break in the dominant arm of the humerus and fell. And he was perfectly independent, but because of that became quite markedly dependent. And of course, to the individual, to the family, and financially, it's a big burden. Now, I'm going to give you some examples of intermittent disorders, and just to emphasize, these are conditions where there's no damage, unlike the other ones with the neurons, but there's a short-lived problem. Why this occurs is a lot of it is up for grabs, but let's see this. This is now a 17-year-old girl. She used to faint when she went to church and had what they considered to be fits, and she was put on anti-epileptic drugs for a long time, which caused quite a lot of problems, and then they realized it was having no effect, causing side effects, and that was very likely the wrong diagnosis. A history of faints before, the warning was variable, she had damaged herself, she promptly recovered when she was flat. There was a family history of fainting, and the only thing to find was she had a low blood pressure, but without a postural fall. So you're going to wonder what the diagnosis is in this condition. We know it's not epilepsy. And this is what was seen when she was tested. When she was put on the tilt table and in the laboratory, there was no fall in blood pressure. But the moment she saw a needle, and they had the needle, down came the blood pressure, down came the heart rate. Now, these nerves are functioning, but for some reason, the sympathetic nerves to the blood vessels dilate. So the blood pressure falls because the vessels are dilated. And for an unknown reason, the vagus nerve overreacts and slows the heart rate. So that's known as autonomic mediated syncope. Also in the subgroup here is vasovagal syncope. And so that's the diagnosis in this case, autonomic mediated syncope and vasodepressor predominantly. So this patient shouldn't have a pacemaker. And this is very important. In the old days, in our experience, a lot of them would go almost automatically to have a pacemaker, which was again horrendously expensive and unnecessary. But you need to be sure. Okay. This shows the difference of why you need the methodology and techniques. When you've got orthostatic hypotension, it remains low for a long period, so you can measure it even with the standard blood pressure cuffs. With syncope, you do need the technology to pick it up readily. Some may say, why do you bother about testing? Because a lot of these people have faints and they get better as they grow older. And it's true, the majority. But if you're getting recurrent faints, you need to investigate to find out which type it is. And this is one example. This is one such patient where the heart rate, as you can see, bump, went right down. So that's known as the cardioinhibitory form. And this patient is the sort who must have a pacemaker. So should go pretty well to the cardiologist and have a pacemaker put in. I'm going to give you another example. We talked about that 17-year-old man who had the fracture. He had fallen. He'd had blackouts for no reason at all. One occasion it was related to shaving. No previous medical history and nothing to find except for the injury. So we're going to say, what is the diagnosis there in this gentleman? And you've seen that before. So I'm going to go through this. And now, we tested him before I go into that, and we couldn't find anything. So he didn't have orthostatic hypotension. We couldn't induce anything on the tilt table. He didn't have vasovagal syncope. But the only thing then we had to think of, because he's in the right age, unfortunately, as we get older, many things tend to be less effective, particularly in the nervous system. But for some curious reasons, the nerves in the neck become more sensitive. They feed the information into the brain, you will recall, you see, in terms of maintaining blood pressure. And in this particular gentleman, as I think I've lost you can see that the heart rate drops the moment he's had unilateral carotid sinus massage. Now, I quickly add, before you do that, it's very important to make sure that there's no atheroma, no plaque, you're not going to cause a stroke, and so on, you see. But this is an example of carotid sinus hypersensitivity. He was a very unusual case. They're usually bilateral, by the way. He underwent denervation of that by one of our surgical colleagues, and it had nothing to do with that. He became president of the Royal College of Surgeons later, you see, and was knighted. But it just shows that you can do a unilateral, but in the majority, you do need a pacemaker to help with this. So that was the diagnosis, carotid sinus hypersensitivity. And I'm now going to go on to the last case. Of a 23-year-old lady, and you might say this is unique, referred by a cardiologist, but this is increasingly so now. She had dizziness when she was upright. She had palpitations, usually when upright, and even after mild exertion. She was quite fatigued. She also had headache, which was worse when she was upright. And only on examination, essentially nothing to find. So no neurological cardiac, except that she had a marked rise in heart rate of over 30 beats per minute. So lying, say it was 80, upright, it went up to 116. I mean, it really should go up by about 10 or 15 only. So what's the diagnosis? And this is what was seen in this sort of a patient. Normally, you get no change in blood pressure and heart rate. In this patient, the blood pressure is low, but it's not falling, unlike the other patients. But look at the heart rate. It's going up quite markedly when upright, and then comes back when they're sitting down or lying down. And this is called the postural tachycardia syndrome. And this is a disorder which now occurs in young people. It's really been described since the start of the millennium, so in the last 10, 15 years. This is what you might see when you use the blood pressure machines and the heart rate machines we were talking about. Normally, I'm not sure what's happened to the L there, it should be there, you get, well, small changes in blood pressure and heart rate. In a patient who's got POTS, it's going up and down. And you're going to find out why. This is why it's so important to have the diary, which I don't think, sorry, I'm going to see, no, the diary. But if we go back to that slide, if you check on this over here, you'll find that they're standing up each time or exercising. At night, when they're lying down, of course, you don't get it. So that's typical of the postural tachycardia syndrome. In the old days, I used to call this the Manhattan skyline. In the present days, unfortunately, it's the London skyline. No, I should say fortunately, it's a measure of that. And I don't know about the Chennai skyline. We talked about the Bangalore skyline a few days ago, which is catching up. So the diagnosis here is the postural tachycardia syndrome. I won't be going into further details on this because we'll be talking a little bit about this later. But I just want to make one point. There's one strong association that we've found. And this, I give you an example of a patient who's a nursing sister who had followed up for many years. And when she came up later, we knew we'd find out what the cause was in due course. She came to me and said, did I know that she was a very good dancer when she was young? And I said, no, I don't usually ask these questions in the outpatient clinic. And she said, she was in her late 40s, early 50s. And she said, this is what I can do. This is in the audiovisual department, by the way, not in our clinic. And she could do that. And I was reasonably impressed because I certainly can't do it. And she could do that. And she could do that too. Now, none of you are impressed because I'm sure you can all do it possibly, but she had what's called the joint hypermobility syndrome. There are many ways to evaluate it, and one way is to try and get your thumb. You can test yourselves while you're here against your forearm. If you can't, like I am, if you can see the skyline there, then you don't have, the chances are you don't have it, but so that's one thing. We know now there's a very strong association between various, it's a connective tissue, well, condition, I wouldn't even call it a disorder, condition, because some people are top athletes, gymnasts, dancers, ballet, Bharatanatyam, and so on, with no problems at all. And it's part of a condition called Ehlers-Danlos 3, which there's no time to talk about. So this all forms part of what we call the intermittent disorders, which are actually very common. So syncope, the first, can affect a large number in the population, and we now know that this is an underdiagnosed, underreported, this is about POTS. Oh, I'm sorry to put this up. I don't know. It slipped in, by the way. If I know I've gone through it very quickly, you can always go and look up some of the details. This is one of the books in terms of the autonomic nervous system, you see. So I think at that point, I would like to close, and I hope I've given you some idea of the disorders, fixed disorders and the intermittent disorders, given you some examples of what goes wrong and why, not had time, obviously, about treatment, but also given you some real examples in life as to how these patients present to you and how you should consider the diagnosis and then move forwards. Thank you very much indeed.